I have no good place for my chat box now so that I can see all of your faces. Okay. All right, so today we're going to talk about chapter 18, which covers skin diseases and diseases of the internal tissues. So most of these we've heard of before, we've seen before for the most part. So it's kind of a lot like a review for us, just kind of grouping them in a different way, give us a better sense of the diseases that they cause in the body. So we have a little group work to do for that. And then we will transition into lab, which is more principles 3. And I have a couple videos for us about setting up the sterile field. So they're not that exciting. Well, I actually have 3. I have one from our favorites, like tips guy, Surge Tech tips guy, but I have a couple others that are older, but I think kind of go over the sterile principles. So we'll see how much time we have. Whatever we don't have time to watch, I can always post on the Blackboard for you. And then we'll do a Kahoot, and then we have a post-test later at the end after class. Okay. How did your experiments go? You guys got your deliverables in, I saw. Yeah. Did you guys have fun?
I had to clean out containers that had all kinds of funky stuff growing on it. And it was really, actually that part was the most fun because like dumping it down the drain, one of the things that grew was like this snotty, slimy, congealed mass. And it like just sat there on top of the drain and it wouldn't go down. And I'm like, I don't want to touch it. I don't know what this is. But it was almost fascinating at the same time. It was just like, you know, and of course I'm trying to get my family. I'm like, oh my God, you guys come look at this. They're like, ugh. Yeah, that was my favorite part.
That's awesome. I love that. Good. I hope you have a picture of that you can show us some of the slimy stuff. No? No pictures of the slimy stuff? Okay. Ariana said she found it interesting, the whole idea of composting. That's what she did her project on. I can't wait to hear more about that. That does sound really interesting. Very good.
Yeah, I'm pretty excited to kind of share a little bit more tomorrow. So
good. I'm gonna make the lineup. It's just gonna be random. I have like this app where I can just assign like random groups. So I'll just it'll just be luck of the draw. So we'll start those tomorrow, which is a good segue into tomorrow. Presentations will be due if you can just upload those to the Blackboard. And then we have about an hour or so to work on presentations. I think we have like 3 or 4 meetings to be able to get those finished. So that'll be fun. All right. Without further ado, we will move into our group activity for today. Any like new takeaways from this chapter? Like I said, I know a lot of it is review, but were there any like aha moments or new things that you were like, head scratchers? The bone glue. Yeah, right. And antibiotics. Yeah, that we actually use that quite frequently. And sometimes if we have individuals that have like a total joint infection, like a knee is more where I've seen it used. You know, they'll take out the implants from the knee and then they'll just put in a big block of cement. They just make like this big square spacer out of it and just load it with antibiotics, mix it up, and then they'll shape it into kind of a block and they'll just stick it in that space where a knee used to be and sew it back up for a while. And then later we'll bring them back and try to, you know, put another knee in. But they can't be weight bearing, you know, they can't use that leg at all while that process is going on.
So do they put like a cast or a brace or something like that, so it's not just some floppy appendage out there, you know, when they're laying in bed or whatever?
Yeah, we have these braces that we put on. They're, you know, probably about 3 feet long, I would say, and they have like a variety of straps, you know, and it kind of encompasses like mid-thigh to mid-shin, I guess, and so we'll put them in that. Yeah, good question. Ariana says, oh, some things about acne. Ian says, acne being an infection amuses you for some reason. It's that opportunistic bacteria striking again. Yeah, right? So, yeah. And there are some, you know, a lot of times they will prescribe oral antibiotics, or there's like Accutane, which is pretty, can be pretty dangerous. And so, you know, you have to routinely go in and get a blood draw and those kinds of things. But yeah, can definitely. And then interestingly, I think, is overwashing of your face. So underwashing can contribute to acne, and overwashing can contribute to it as well, because we're washing off the normal flora. So, you know, it's kind of like finding that balance. I can remember, I don't know if you guys have ever been to the Arizona Science Center, but they have like different, they could like showcase different things. Like sometimes it'll be dinosaurs, or other times it'll be whatever. And this one particular time was like skin diseases. And I remember them having like this interactive display where you actually push these buttons to see like how acne like erupts like up through the dermis and epidermis, and then, you know, like becomes a pimple or whatever. It was pretty gross, but very interesting at the same time. Okay, good, very good, yes. Awesome. Okay, so here's our objectives. Let me break you into groups, and then we will talk about that. 5 groups this time. Let me just make sure. Yeah, okay. 5 groups. First group, Alyssa, Gabe, Ivana, Lixie, and Rulan. And I'm just going to go with the one at the top. So Alyssa, can you be the group leader in that one?
Yes.
Thank you. Group 2, Ariana, Jonathan, Rainey, Robbie, and Tallman. So Ariana, can you take the lead in there?
Sounds good.
Awesome, thank you. Group 3, Adriana, Alexis, Jackie, and Wendy. So Adriana, are you okay to take the lead in there?
Yeah, I can do it.
Sorry, I have like half of my screen covered. I can't put these boxes anywhere where I can see all of your faces. I apologize. It's probably just my Mac, because Macs have a tendency to be kind of strange. Ian, okay, room 4, Ian, Jacob, Tori, and Tammy. So Ian, you'll be the group leader in there, please. And then last, Andrea, Hannah, Sarah, and Sean. So Andrea, if you'll be the leader in there, that would be fantastic. Okay, so group 1. Group 1, you are going to have the section on bacterial skin infections. Group 2, you will have fungi. Group 3, viral. Group 4, vector. And group 5, internal. Okay, so what you're gonna do is, let me see, let me just give you an example. So for group 1, who has a bacteria, you'll look at your subheadings, which are staph, strep, pseudomonas, acne, Hansen's, and cutaneous, anthrax, and gangrene. So the objective would be to grab an image that represents each one of those, And then when you do your little presentation, like if each of you want to take an image or something, you can just tell us why you picked that image, what it has to do with your subheading, and then find 3 to 5 interesting facts about your subheading. It doesn't have to be, it can be specific within the topics, or it can be generalized to bacterial infections of the skin. Okay, does this make sense? All right, so you're gonna grab a picture for each of the subheadings, make sure that you can say why, and then 3 to 5 interesting facts. Okay, questions? All right, I'm gonna give you about 15 minutes. That'll take us to 9:30. All righty, if you need something in the meantime, give me a shout, okay? All right, here we go.
Okay, so the first one that we have is Staphylococcus, and it looks like the grape clusters. And then their 3 facts are that it's the most common skin pathogen, it can attach to hair follicles, and it is often treated by incision and drainage.
Very nice.
Okay. So here's a photo of necrotizing fasciitis. It is caused by group A streptococci. So these pictures were really fun to look at. Some facts about it are group A is found on the skin, or it can be found on the throat, aka strep throat. People can carry it with no symptoms. And another condition is impetigo. Okay, and now we're going to move on to Pseudomonas infections.
Okay, so Pseudomonas infections is one of the many infections, but the main one is the aerogeonios, if I'm saying that right. And it's mainly one of the main infections found in humans and found in swimming pools or hot tubs. And you see in the picture, that's what it's caused by low maintaining the pools, low count chlorine. And one of the facts I found was that it's 2,700 estimated deaths in the United States in hospitals after surgery, and it is becoming a multi-resistant drug, more immune to antibiotics.
That's crazy.
Okay.
Now I look back at it, I'm not sure if one of my kids had this or not, because the symptoms kind of look like what's staring. But I'm done.
Okay. Next, we have acne infections. So, just a second, I'm going to pull it up.
Acme.
Mm-hmm.
So as she's pulling it up, it's a bacterial skin disease. It's characterized by inflammatory pustules, cysts, and papules. And from what I found, it's just caused by blocked channels in the skin. It's one of the most common skin infections in the United States, and it's not really dangerous, but it leaves scars on your face or just wherever it forms. And the risk factors for it, it's genetics, menstrual cycle, anxiety and stress, hot and humid climates, and using oil-based makeup, and also just squeezing the pimples.
Mm. Yes, I don't think you're sharing anymore, Alyssa. Oh, there she goes. Okay.
Sorry.
Oh, poor baby.
Yeah.
Yeah.
Okay.
And hers is especially bad because you can see how like inflamed most of them are.
Yeah.
And, yeah.
Aw.
Also, I want to send this picture in the chat real quick.
Okay.
I found this a little bit earlier. I just thought this was weird because it's a cat that has acne.
Oh.
And
That's totally common for cats, by the way. They tend to get a lot of chin acne, and it needs to be resolved with antibiotics usually, and it reoccurs frequently. They get cysts and stuff underneath their face.
Is there a reason for that, Tori?
There could be a couple of reasons. A lot of cats have diabetic issues just through dietary reasons, and they think that could be one of the causes. Is dietary issues. They also suffer quite frequently from hyperthyroidism, so they think that could also be part of the issue as well as allergies can cause those little pustules.
Oh, poor little kitten cats.
Okay. So this one is Hansen's disease.
Okay, so it's also known as leprosy. Sorry. There are two forms of this disease. It's both neural and there's also cutaneous. And then the third is the pathogen may be found in Schwann cells.
I don't want any of this stuff.
Okay. Our next one is cutaneous anthrax. And Lixie found that one.
3 facts I found on that one was it's spore forming, mainly affects animals, rod-shaped, and can be used for bioterrorism attacks.
Wow. Yes, it's good for bioterrorism.
And lastly, we have gas gangrene. We kind of all tried to do this one because we have 7 subheadings and there's 5 of us.
so gas gangrene can pretty much occur anywhere on the body, but it's most commonly it most commonly affects the arms and the legs. And it occurs when open wounds from an injury or surgery are just exposed to bacteria. And it's pretty rare, but it can be life-threatening if it is left untreated.
Mm. I think we can just pluck those toes right off. What do you guys think?
Yes.
This picture, all the pictures I found are so, they look so gross, but it's so cool.
Yes, it's too horrifying to look away. Nice job. Very good. Good job. Questions, comments about, great job, by the way. I know you guys had a lot of headings about bacterial skin infections. Those are some good images that'll be burned in my mind for quite a while. All right, great job. Okay, let's move on to group 2. Ariana's group had fungi. And who's going to share?
So I have a link for you to open up if you don't mind.
Okay.
Let me just get that sent over. And that is our Google Docs.
All right, 1 second. Let me get that pulled up here for you guys. Okay, let me share my screen with you. There we are.
Cool. So we had fungal skin infection. And our first one is the cutaneous mycoses. So they're a superficial fungal infection that spreads easily and is also known as a dermatomycosis, or that's kind of the technical term that you'll probably hear more often in the field. And then it's also known as the ringworm because of their apparent red ring around a white scaly region. We were talking about this one and discussing how easy it is, or it does spread easily, but we were talking about how like people in sports usually contract it pretty easily because of their sweat, and pretty much you see it in like athlete's foot and all of that good stuff. And then you have subcutaneous mycoses. That right there is a more serious superficial infection, and it's contracted by, it's a soil-dwelling fungi. You'll see it as thrush or candida, and it's known as sporotrichosis or trichosis. And it compromises like the diabetics or anybody like a steroid or antibiotic therapy. And then you see that picture right there of Jonathan took all of these pictures. He's the one that has credit for them, so I think he knows a little bit more about the pictures that he picked. And then the last one is going to be systemic mycoses. So it is more difficult to diagnose and treat, and it does attack lung tissue. And I could try to say this, but it's, I think, a little too early to try to say this. So I'm going to skip it over, and I'm sure you can read it. But histoplasmosis and all that good stuff, but it goes through the bloodstream and attacks the central or the CNS. The gastrointestinal tract, the circulatory system, the eyes, the bones, the joints, the skin, and it provokes fatal consequences for the patient, as in systemic candidiasis. So you can see the picture right there of their tongue and all that nasty stuff. And then just a little bit more like fun facts. It lives as a saprophytes in soil. It causes organ failure and spreads via the bloodstream, or in short, or whatnot.
Poor little baby mouth.
Mm-hmm.
All right. Good job. Good facts.
Thank you.
Good pictures. Questions about fungal skin infections? Nice job. Ringworm. Oh yeah, Ivana says her brother had ringworm from wrestling. There you go. That supports what you guys were saying, Ariana.
Yeah, so anybody who, I think that's what Robbie came up with. She said that she was, what was it that you were saying, Robbie, about she was like managing a wrestling team?
Oh yes, it's really common for like for when you sweat a lot. When I used to be a manager for a wrestling team, a lot of the wrestlers would get it. like all the time because of the mats not being disinfected or cleaning really right, and the sweat touching, and if they weren't clean, like their skin as well, touching, and they'll get it a lot. In sports too, it happens a lot too as well.
Very interesting. I had no idea. You guys teach me stuff. All right, very good. Let us go to viral skin infections. That was Adriana's group.
I'm going to be sharing my screen.
Okay, let me help you with that. All right, you are set to go.
Okay, so the first one we had was chickenpox. And chickenpox is a respiratory infection caused by the varicella zoster virus, and it's characterized by local vesicular lesions on the skin of the face, thorax, and neck. The vesicles fill with pus, rupture, and form scabs. This is just a picture of it. And one of our facts was more than 6 million doses of varicella vaccine have been given since it was first licensed in March of 1995.
Wow.
And then the next one we had was shingles. And shingles is basically a different form of the disease chickenpox, but it's less severe. It inhibits lesions similar to chickenpox, but they tend to be more localized and typically occur only on one side of the body. Something we found is that they use prescription painkillers and low doses of antidepressants to treat. Can you guys see this image?
We're still looking at the shingles one.
Okay.
I might have to stop and then reshare. I have to do that sometimes.
Okay, can you see it now?
Yes.
Okay, so, and our last one was smallpox. So smallpox is caused by the variola virus, and they form lesions that are unrecognizable, and they're highly disfiguring. So you can see the little boy on the left has smallpox. And one of our facts, smallpox is thought to date back to the Egyptian Empire around the 3rd century BCE, based on smallpox-like rash found on 3 mummies.
Wow, they found it on mummies. Very interesting. Huh. Cool. That's awesome. I wonder if they found it on their mummies' cats as well. They used to just raise cats just to make them into mummies. So weird. Very good, very good, very good. I think they do go away, Rainy. They just leave, don't they just leave scarring? I don't think they look raised like that forever. I could be wrong. What did you guys find?
Yeah, I'm not sure if I'm not really sure. I know Alexis found the picture. Alexis, do you happen to know?
Because in that image, was that like a before and then after of that same boy? It kind of looked like the same boy. Let's see if we can find out.
So, according to Harvard, it says that after about 2 weeks, they will scab and fall off, but they'll leave pitted scars. and most will be gone in 3 weeks.
Very good, very good. Well, not good, but yes, understandable. Look at this picture right here. This is a child mummy. Wait. A child mummy that they think had smallpox. Isn't that crazy? Okay, good detective work.
So the scarring went down to the bone.
Yeah. That's crazy. All right, very interesting. How about vector-borne infections? You guys just had a little snippet. What did you guys come up with?
So I'm going to go ahead and share my screen.
Okay. Hold on 1 second. Let me do that for you. Okay, you are good.
Okay. All right. So for vectors and our little tidbits here, so Jacob found the first one here. So malaria is a parasitic infection transmitted by mosquitoes, more specifically the Anopheline mosquitoes. And it's estimated that 219 million cases globally and results in more than 400,000 deaths every year. Most commonly, the deaths occur in children under 5 years old. So that's a picture of a little mosquito there. And then let's see here. Oh, I copied the wrong fact for that one. Hold on, give me like 2 seconds.
No worries.
Let me stop sharing for just a moment so I can pull my stuff back up. Sorry, guys.
That's okay. These things do happen. I do those things all the time.
Being human, right?
Yes.
All right, and so this guy right here, this is the parasite that causes Chagas disease. So that's the name of it right there. I'm going to try and say it. Let's see if I can. Trypanosoma cruzi is
really good.
what this is called. And it's approximated that about 6 to 7 million people worldwide are affected by Chagas disease, by bites from this guy right here. I think he's also called the kissing bug. I think that's the layman's term for him. But it's mostly people in Latin America countries. And then Tammy's going to share for this dude right here.
So tularemia is caused by Franciscilla tularelis. Wow. And it's caused by like a tick. It's caused by the tick, and it's also known as rabbit fever or deer fly fever. And it can't actually be it's generally not transmitted from person to person. It is in the feces, and so it can be contaminated in dead bug carcasses. And so if there's any handling of those, and also bites as well. And so then it causes the skin lesions and the skin to look like the sores as you see in the picture.
What about eating parts of bug carcasses that are in your cereal?
Wow.
There's like a parts per million of how many bugs there can be in our cereal.
Oh my gosh, gross. I would say that would be a contributing factor. I didn't really think bug carcasses in my cereal though.
Me neither. I just thought about it right now. I read some article about that.
I don't eat cereal.
Yeah, right? They gotta cook them first, Rainy. They got to. Molasses grasshoppers. But not with your cereal though. No? It might give like a little extra added crunch. You know?
I mean, I hear they taste like chicken, so.
Everything tastes like chicken. It's like the universe's favorite animal. Raisin Bran Grasshopper Crunch. Yum. Mm-hmm. Delicious and nutritious.
Feel the leg in every bite.
It reminds me of Fear Fact. You know how they would eat those bugs and have like,
Yeah, I don't know how good I would be about eating bugs. Ostrich is red meat. But it's a bird. Yeah, that's interesting. Yeah. Uh-huh. I love fun facts. Good job with the vector-borne infections. Any questions about those? Besides why it's called Rocky Mountain spotted fever when you don't get it in the Rocky Mountains. You know, other than that, everything seems pretty straightforward. All right, fantastic. Thank you very much. Okay, so last but not least, internal tissue diseases, deep tissue diseases. And that was Andrea's group.
So I'm going to share my screen for that.
Okay. All right, you're good to go.
I don't know if it's working or not.
I don't see anything yet.
Hmm.
You see the little green arrow at the bottom if you like hover over the bottom of your screen?
Yeah, I'm clicking that and nothing's coming up. So I don't understand.
You don't get like a little white screen that pops up at all.
No, it says share screen, but I'm clicking on it and it's not allowing me to.
Do you want me to do it instead?
Yeah, if you want to do it.
Okay, let me switch to Hannah.
I'm just gonna have to click on the links though, so it'll be like, it won't be one document, but I guess that works.
We'll make it work. Okay, Hannah, you're good.
Okay, one sec. Sorry, one sec. It's like loading.
Lexi, all we see is your wall. Can we see you?
Okay, can you see it?
Yes.
Okay, so I had arthritis, which that's like a pretty severe looking arthritis. It's pretty nasty looking. The fingers are kind of like, sideways. But arthritis is an inflammatory disease of the joints causing pain, edema, and restricted movement. There's two different types of arthritis. There's osteoarthritis and there's rheumatoid arthritis. Osteoarthritis affects millions of people around the world. It's like the most common. It's due to the wearing of the cartilage on the end of the bones. And usually that's due to like degeneration. So when you move and everything, it would just be bone on bone and it causes pain. And like eventually your fingers could look like that. Yeah, so it's mild to extreme. And then rheumatoid arthritis is an autoimmune. And it causes like the body to produce antibodies against its own cells and tissue. And then you can also get septic arthritis, which is due to like a bacterial invasion into the joint. And in the book, I think it says it could be due to staph or I think tuberculosis or even salmonella. Yeah, that's the first one, arthritis. And then I'll pull up the next one, which is going to be okay, Sean did 2 of them, so this is the first one. Is that the right picture, Sean?
Yeah, that's the right picture.
Okay, cool.
That's what's known as lymphadenitis. I chose that picture just because it's a pretty good representation of what swollen lymph nodes would look like in the throat anyway. And there's a couple things about it. This disease can result in multiple swellings at the same time, more than just one lymph node, so it can happen all over the body. If the inflammation doesn't go away, they often need to get a biopsy, and then sometimes it can lead to the need for them to be removed. And then in really bad instances, if the bacteria gets past the body's defenses, gets past the lymph, it can get into the lymphatic vesicles, which can then cause septicemia. And you get like these red lines that move away from the infection towards the heart. And it's like a little timer. Once it gets to the heart, you die.
That's so creepy.
Yeah. And then the next one. This is osteomyelitis. And I chose this picture here because I felt like it was pretty good at kind of showing what it looks like when the bone is deteriorating. And, you know, it wasn't an x-ray picture, which all the other ones were. Interestingly enough about this, it's actually most often seen in children and adolescents with rapid bone growth, so growing kids. It unfortunately can also cause these growing bones to become shortened once the disease, you know, blows over. It can actually stunt the growth. And it not only targets bone, but it can also target the joints as well. So it's fun stuff.
Okay, I think this one's Sarah's, right, Sarah?
Yeah, but I had sent the wrong one.
Oh, is it the second link? I think.
Okay.
Is it that one?
Yeah.
Okay, hold on.
Okay, so for this, it's the bacterial fasciitis. And then a few facts. It's a dangerous infection of the soft tissue, starts in the subcutaneous tissue. Most commonly occurs in the arms, legs, and abdominal wall. And then prompt surgical removal of dead and infected tissue decreases the death rate. I think that was the only one I did.
Okay, and then Andrea, do you want to send me the link to the one that you had since I'm sharing now?
Yeah, I'm gonna send it to you. I think I only sent it to.
Okay, I don't see it. If you just want to send it, I can.
Yeah, yeah. Okay.
Okay, cool.
So I did a breast tissue infection, and if breast tissue infection actually goes untreated, it can become breast abscess, which is pretty much a pocket of pus that forms a lump inside of your breast. But that's very rare. But this is most common in women that are breastfeeding because the bacteria from the baby's mouth enters into your breast. But other than that, it's not very common. But you are more prone to it if you have diabetes, and it is treated by draining all the abscess with a needle.
I think it's interesting that, you know, when we read about this, like, it doesn't talk about males whatsoever, right? Like, there's no way males could ever have anything wrong in this area, but it definitely can. You know, it's just, it's probably less common than women having it, but, you know, definitely have issues as well.
All right, and then I'll stop sharing. I think that was all of the ones we had.
Awesome. Yes. Very good. Very good. Awesome. Questions about material in the chapter? I think this was a fantastic review. What do you guys think? It was a good review. Very good. Some surgical stuff relative to what we're seeing in here, right? Individuals that have burns, I think that's one thing that stuck out to me in regards to like Pseudomonas infections. And, you know, we could be bringing those individuals back several times to do debridements and those sorts of things. And so a lot of these are really going to be debridements or INDs that we're seeing in the operating room as a result of this, these types of infections. So sometimes in older individuals, we will see osteomyelitis in the feet a lot of times, and they'll have to like do a resection or take out, you know, that part of the bone, or maybe even an end of a toe or something like that. And then as far as arthritis goes, whether it's rheumatoid or osteoarthritis, that's when we kind of get into our joint replacements. You know, sometimes I've been on cases where we've had individuals that have rheumatoid in their hands and will replace like all of these joints right here. These proximal interphalangeal joints. So those are some of the things we'll probably see in the OR the most. All right, great job. Give yourselves a pat. Okay, let's take about a 10-minute break. I have 11 after, so if you want to come back at 10:21, if we're being true to our 10-minute break, and then we will switch gears and talk about some lab principles. Okay? All right, I will see you in a few. Okay, I'm going to share my screen with you so we can take a look at the principles, and then I have one image I want to show you. I couldn't find the other one that I was looking for, but we're going to start right here at this one that says scrubbed personnel should stay close to the sterile field throughout the procedure. Part of that being we don't want to turn our backs to the sterile field. And we already know that. We've already talked about that before, but just to reiterate, that we always want to be facing whatever areas are sterile. We don't want the sterile area at our back because we can't see it. So we can't judge how close are we? Are we far enough away? That 12 to 18 inch gap that we're supposed to leave between sterile and non-sterile, right? So this gives the little note that in some situations, such as procedures that involve a large sterile setup and or participation of many sterile members, that we may be required to move about more. When we move about more, that increases the risk of contamination. A good example of this is if you're doing some sort of breast surgery, the surgeon's going to want to be on the side with the breast he or she is working on. So if it's a breast augmentation, a breast lift, a mastectomy, whatever the case may be, they're going to want to be on that operative side. So if you're doing a bilateral breast case, then there's going to be some movement. The surgeon's going to want to switch places with you, because typically as the surge tech, you're across the field from the surgeon. That's the best place for us to be passing across to our surgeon. That's what we like the best. So when you do move, a lot of times you're going to have to move your back table as well. The Mayo stand can stay in place, but a lot of times you're going to have to move yourself and you're going to have to move your back table. So that just means being extra careful while you are moving to make sure that a contamination doesn't occur. And that kind of leads into that next concept of movement being kept to a minimum. When we are gowning, when we're drying, when we're draping, when we're opening things, when we're setting up, no matter what it is, you want to limit movements. And we're going to help you, kind of keep this in the back of your mind. Because when you start setting up the sterile field, your Mayo stands over here and your ring stands over there, and we're going to ask you to just kind of bring those closer together so that you don't have to travel so far as you're setting up your sterile field. So limiting movements by both sterile and non-sterile people is going to be important, because that is going to reduce the risk of contamination. And then we already talked about before about keeping traffic to a minimum. How many people are coming in and out of the OR? You don't want to just go, let's say that you don't have a case. And so you're just kind of going from room to room to room, kind of checking out what other people are doing. If you don't need to be in that operating room, do not go in there. It's just increased added traffic, and it's not the best technique to use. So we want to limit our traffic in and out as much as we can. That's why it's important to make sure before we start opening our sterile things that we have everything that we need in there, so that we don't get our stuff opened and then we're like, oh, we forgot our gown. So we go out, we get our gown, we come back in, we open it. Oh, we forgot our gloves, so on and so forth, right? So we want to make sure that we limit that traffic as well. And then we're going to skip up here. The last one is, so the movement continues up at the top here. And then we're going to finish up with this last little one that says sterile surgical team members should either pass while facing each other or pass back to back by rotating 360 degrees. Why do you think this is? Why do we choose front to front or back to back to pass each other? Any thoughts?
It seems like that way you're keeping sterile to sterile or non-sterile to non-sterile.
Yep, you're absolutely right. You're absolutely right. Let me see what Ian is adding. Yep, you're absolutely right. So if we think about where the gown is sterile and where it's not sterile, it kind of makes sense, right? Even when you're passing something that's not sterile, as long as your back is into the field, it's better if you see what is not sterile that is in front of you than to turn your back to it. But we'd always want to know where we are in relation to where the sterile things are or where the non-sterile things are. Okay. And I wanted to find you a picture of this passing front to front or back to back, but I was not having very much luck there. But I do have one image I want to share with you. I have to stop and switch gears here and grab my browser. This is where I was trying to find front to front, back to back, but I really can't. I couldn't find anything, but I wanted to show you this. This is a total knee setup. And there is a lot going on here. There is a fluid warmer over here. Can barely see it in the corner. This is a fluid warmer. We put a sterile drape inside of it that hangs over the edge. Saline goes into it. You can see the bulb, the asepto floating in it there. So that's one sterile thing that we have. We have 2 sterile mayo stands. We have 1 table that is just all drapes and gowns and gloves. We have 1 table that is going to be like our general orthopedic stuff. Let me zoom in here for you. So this is, yeah, it's some general stuff, but they have some total knee stuff over here. But you can see this is the string from their ortho tray. They have their saw and their drill here ready to go, their mallet, other various like general instruments that you know, the facility will have. And then all of these over here are the specialty, all of this stack here. So the reason that I wanted to show you this, and the reason why the toga is a good idea, is because when you come up to the field to do that total knee, this table is going to be at your side, like at the end of the OR table, and this table is probably going to be at your backside. All right, you don't want to bring it all the way up so that you're rubbing your derriere on it, but they're going to be at right angles to each other, just like you see here. And you're going to be working with this table more than you probably are this table. So one's going to be at your side and one's going to be at your back. All right, and then the rest of these things are going to be gathered around you as well. So movement within the sterile field with a setup like this is even more challenging because you have so many more sterile things. If you're just doing a breast biopsy, it's pretty much 1 back table, a small one, and a Mayo stand, and that's it, right? And so we don't have as many things to worry about. Does that make sense?
It uses all the back tables.
It uses all the back tables. It feels like it uses all the back tables that are in the entire OR. I know when I was doing total knees there at the facility that I was working at, there were 2 really long back tables. And so I would make sure that I got there early so that I could go swipe those from other rooms and replace them with whatever one that was in my room so that I had the 2 long tables. Although I did work with one, she was actually an RN, but she was a scrub in her past life. And so she would scrub some of the ortho cases at the hospital I was at. And she would use a table that was extremely small, probably like half the size of this table here. And things would just be stacked up like 7 and 8 trays, like high. And I never saw her do a case. I don't know how she worked off of a back table like that, but apparently she did and did it well. So, you know, it doesn't mean that this is the only way to do it, but typically it is the way that we do it. Questions or comments about our 3 principles for today? I have a couple videos for us. Let's see. Again, they're not extremely exciting, but I think they are very informative. So let's check this one out first.
Once all the case supplies are opened and the surgical technologist is scrubbed, gowned, and gloved, the next step is to arrange the instruments on the back table and Mayo stand in preparation for surgery. Begin by draping the Mayo stand. Then, organize the drapes. Set up supplies such as suture, suction, DSU. Arrange all instruments. Label medications, syringes, solutions, basins. Place the instruments on back table and Mayo stand. Perform an instrument, sponge, and sharps count.
Blades.
1, 2, 3.
Suture.
1, 2, 3. 1, 2, 3, 4, 5. 1, 2, 3, 4,
Okay.
5. Latex. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, got it.
Instruments.
Yeah.
1, 2, 3, 4.
Got it.
1, 2.
Okay.
1, 2, 3, 4.
All right.
1, 2, 3, 4.
Okay.
1, 2. 1, 2. 1, 2.
Okay.
1, 2. 1, 2.
Okay.
1, 2. 1, 1, 2. 1, 2.
Okay.
3, 4. 1, 1, 2. 1, 2, 3, 4.
Okay. Practice. Okay.
2.
2.
1. 1, 2, 3.
Okay.
1, 2. Suction.
Okay. Mhm. Okay. So I'm going to have my peeps with last names starting A through L, put into the chat box what you observed. Let's have the rest of you watch the chat box, and then after a couple minutes, Then we'll have you add anything that you did not see. Okay. A's through L's. Observations. ST showed each sponge to the circulator. Awesome. Absolutely. That's very good technique. That's what we want to do. Labeling medications. Oh yeah, the roll towel. Good. Concise with the count. Good. Yep. Counting out loud. I think the reason she did that, Jonathan, was to show that little blue tail. I think that's why. That's the like the radiopaque, you know, that would show up on an X-ray. She bellied up when she draped the Mayo stand. Yep. Instruments were counted separately. Yep, by type, right? Good. Who else hasn't chimed in? Count of instruments by name. Yes. We'll talk a little bit more about that. Yes, they can be miscounted easily, for sure. Good observation, Wendy. Yep, we call those sponges. Yep, so the big ones are lap sponges, like the big fluffier square ones, which open up to be, you know, yay. And then the smaller ones that are the 4-inch by 4-inch, those are called Raytex. And they can be detected by X-ray, both of them. Well, that's an important thing. Good. Okay. What about my other half of the class? Things that weren't already identified. What do you guys got? Yes, separating the individual instruments. We totally do that. Yep. So many instruments. Yes. She draped the Mayo stand first. Good. Alyssa, that was going to be one of my questions. What did she do first? Very good. Yep. That's typically what we do first. Anything else? Yep, Ian, you got it. We do the counting and then they're going to be the ones that verify and document. Yep, and in the lab, you will play the role of the circulating nurse. So you will be doing that. It'll be fun. Oh yeah. Good organization skills, Rainey says. Anything else? Let's see, I wrote down some notes. What did you notice about when she was taking some of her instruments to the Mayo stand? Did you notice anything special about that? Anybody catch anything?
The main one that we're going to be using for the procedure.
Yes, so she's going to put up there what she's going to use for the procedure. But did you notice how she took more than one at a time? She didn't just take one and go put it on the Mayo stand and come and get another one and go put it on the Mayo stand. What principle was she following there?
Limiting the movement.
Yeah, limiting movement. So what I typically do when I set up, and you guys will see this eventually, is the instruments that come on that little rail, that's called a stringer. And you saw that she pulled that apart and set that to the side, right? All of her ringed instruments were loaded on that. And then what I typically do is I'll go through and I will gather every single ringed instrument that I need to put on my Mayo stand, and I will take all of them up there together. So just another thing that we can do to limit that back and forth. Did you notice her basin set was pulled right up next to her side? So all she had to do was just kind of turn at the waist to get what she needed and place it on her table. Again, that limiting movement. And so even though this video wasn't that titillating, I think that it really showed how that, you know, how we can put that principle into play. Did you also notice that she didn't place something on her table and then move it somewhere else and then place it and then move it somewhere else, right? We want to have this plan in our head where we know where it goes and we put it there and we leave it there. All right, we want to limit the amount of times we even move stuff on our back table, because the more we handle stuff, the higher the chances that it's going to go south for the winter, okay? And then it's trash after that, okay? Excuse me.
I also noticed, sorry, that she put her forceps on the side of the tray.
Yes, we definitely do that too to keep them organized. For me, I'll kind of separate them out. Ones that have teeth go on one side and ones that don't have teeth go on the other side, but you can organize them however you want. You don't want to put them along the back edge, right? You want to put them along the front edge. Anything that like hangs over the back edge, there's a risk of it getting contaminated. So, you know, so sometimes we'll set our retractors around the edge of the pan as well. And you just want to make sure that they're not going over the back. Yep, that's a great observation.
Quick question. Is the count sheet the one that comes with the container, or do they have their own separate count sheet?
Yep, it's going to be the one that comes with a container, the one that you guys put in there in processing, or whoever. Yep. At one place I work, I want to say we took them out all together and we just had copies of them in the room. It was a surgery center and we didn't really count instruments that much at the surgery center anyways. So they just opted to take all of the count sheets out and just not use them at all. We only had one sterile processing person. So he just had like a master role. So, but for the most part, you know, it's going to go in a little slip or something with the tray. Yeah, good question. Other questions, comments, observations? There was only one thing that kind of drove me nuts about that video, and it was that she did not say the name of every item before she counted it. And that is something that you will do. You're not just going to go, you know, counting your instruments 1, 2, 3, 4, 1, 2, 1, 2, 3, 4, 5. Like, you're not going to do that. You're going to count out, you're going to call out what the name is. Curved hemostat, 1, 2, 3, 4, 5, 6. Coker, 1, 2, Babcock, 1, 2, Alice, 1, 2, 3, 4, tonsil, 1, 2, whatever the case may be. Forceps, you know, you're going to do the same thing instead of just saying a number. That pretty much doesn't fly. So we will learn to call out the names before we count. Otherwise, I think that video was pretty good. I have one other one. It's kind of second verse, same as the first. It's by the same company. Let me see if I can find it here. Aha, it was hiding. Okay. Let me see if I can get this back.
A sterile field is the physical area at the center of the operative site and all sterile surfaces around it. Some important principles of sterility to remember. Sterile surfaces contact only sterile surfaces. Non-sterile surfaces contact only non-sterile surfaces. Contamination of a sterile surface occurs when a non-sterile surface touches a sterile surface. For example, if the circulator's bare hand accidentally touches the surgical technologist while delivering sterile items to sterile personnel, the field is no longer sterile.
The syringe. Sorry. Contaminated. Look at your another glove.
A sterile item is considered sterile only after it has been processed using methods that are proven effective. Before any sterile item is distributed to the sterile field, the integrity of the wrapper and the reading of the chemical sterility indicators must be verified. Many conditions and events can alter the sterility of the item, including puncture holes or tears in the wrapper, moisture, or failure of the sterilizer system. Sterile drapes, gowns, and gloves, and table covers are barriers between a non-sterile surface and a sterile surface. Materials used as barriers against contamination are chosen for their density, strength, ability to resist moisture, and ease of use. Materials that do not meet minimum standards for patient safety should not be used. The edge of any sterile drape, wrapper, or covering is considered non-sterile. When a sterile item is opened, the edge of its wrapper must not touch the item. Maintaining a wide margin between the sterile item and the edge prevents possible contamination of the item as it is being delivered to the field. A 1 inch or 2.5 centimeter margin from the perimeter of a sterile wrapper is considered not sterile. Sterile liquids in bottles with an edge or lip that is protected with a sealed sterile cap may be delivered directly from the bottle into a sterile container on the field. Medication vials often are sealed with aluminum caps. When the metal cap is pried open, the edge of the vial is considered contaminated. This is because there's no way to remove the top without dragging the non-sterile cap across the lip of the vial. When you begin to pour sterile solution into a container, do not stop pouring until the container is empty. Pull the container away from the sterile field so that no residual liquid can drip down the non-sterile side of the container into the sterile receptacle below. Never recap a sterile fluid container. If there is any doubt about the sterility of an item, consider it contaminated. Before opening the wrapper of any sterile item, inspect it for signs of contamination. Tears, holes, wear marks, or water spots on any wrapper are signs of questionable sterility. When in doubt, do not use the item. The draped patient is the center of the sterile field during surgery. Other draped items and sterile personnel form the periphery of the field. Sterile drapes create a barrier between a non-sterile surface and the working area of the sterile field. For example, the operating microscope, ring basin, and back table are draped. Equipment that is not draped must remain outside the sterile field with at least 12 inches allowed between the sterile and non-sterile surfaces. Sterile gowns are considered sterile only in front, from mid-chest to table level. Sterile personnel should not drop their forearms or hands below waist level, nor raise them above the axillary line. The axilla itself is considered non-sterile, even though protected by a gown. This is because of the large population of bacteria in the axillary region. Sterile personnel must pass other sterile personnel back to back or front to front. Even though wraparound gowns are used in most surgical settings, the sterility of the back cannot be guaranteed because the person wearing it cannot observe it. Sterile personnel never turn their back to the sterile field. The back of a gown is not considered sterile because it cannot be observed by the person wearing it. Sterile tables are considered sterile only at table height. The top of a sterile table is the only surface considered sterile. Suture ends must not hang over the table edge. Table drapes must not be repositioned once they've been placed because this changes the level of the sterile area. Tubing, cords, and hoses that are secured to the patient drape must not be pulled up to create additional slack. This brings the non-sterile portion of the tubing up to the sterile field. It is the duty of the scrub to measure and allow for necessary slack before securing these items in place when they are first brought onto the sterile field. Sterile personnel remain within the immediate area of the sterile field. Scrubbed personnel must not move away from the sterile field. Sterile personnel are sometimes required to move around the periphery of the field to perform their tasks. However, moving outside the immediate sterile area is a compromise in aseptic technique. Sterile personnel should not leave the room to retrieve items from another area, even if that area is restricted. Non-sterile team members never lean over or reach over a sterile surface to distribute sterile goods to the field. When sterile packages are opened, hand items to personnel or deposit them on sterile surfaces in such a way that prevents reaching over previously opened goods. Many commercially prepared surgical items are packaged so that they can be flipped onto the sterile field from a safe distance. If the wrapper does not permit this technique to be used, non-sterile personnel must pass the item directly to scrubbed personnel. Movement is kept to a minimum during surgery. Team members should move around the operating suite as little as possible. This applies to both scrubbed and non-sterile personnel. Traffic into and out of the surgical suite creates air currents that sweep contaminated particles into the operating room. Doors to the operating room suite should remain closed when sterile supplies are opened and when surgery is in progress. Drapes and linens should be handled as little as possible and with a minimum of movement. This prevents the release of lint and dust particles, which create a vehicle for transmission of airborne bacteria. When draping a surface, always unfold the drapes. Never shake a drape to loosen or unfold it. At the close of surgery, fold or roll soiled drapes toward the center, taking care to contain the contaminants. Never drag a drape from a surface and bundle it up against your body, even if you're wearing protective attire. This spreads contaminated particles into the environment. Talking is kept to a minimum during surgery. The mouth is a major reservoir for bacteria. Talking forces the breath into the air and immediate environment. Masks worn to prevent the release of bacteria-laden moisture are not 100% effective, and when improperly worn, produce little protection against the dissemination of aerosol droplets containing microorganisms. Moisture carries bacteria from a non-sterile surface to a sterile surface. When water comes in contact with a sterile drape or gown, it can cause strike-through contamination. This occurs when moisture from either side of the drape serves as a vehicle for bacteria to infiltrate the drape from the non-sterile surface. Most disposable drapes are tightly woven to prevent strike-through. With continuous contact, blood and fluids can penetrate gowns and drapes. Woven, reusable drapes are treated with a chemical that resists moisture but are not completely impervious. The sterile field is created as close as possible to the time of surgery and is monitored throughout the procedure. When sterile supplies have been opened, the sterile setup is vulnerable to contamination. The longer a sterile setup remains exposed, the greater the risk of contamination. Sterile supplies should be opened as close to the time of surgery as possible. In reality, however, cases often are delayed or even canceled.
That's a good review for us. Okay, so let's do the reverse of what we did for the last video, and I'll have my M's through Z's. Tell me some things you heard or observed that were new. Let me have my other half watch the chat, and then I'll have you contribute in a bit. Oh yes, Tommy says clipping the drapes, clipping the cords to the drapes and allowing for slack. Yes, I always say don't short sheet yourself, right? There's nothing worse than that because you can't pull more up. You can dish more off, but you can't pull more up, right? Axilla is contaminated. Yes, indeed it is. Oh yes, when pouring something, don't stop. I always say once you pop, you can't stop, right? It's kind of like Pringles, but a little bit different. Talking kept to a minimum. Yes. Passing back to back. Yes, yes. Sterile drapes create a barrier between surfaces, between sterile and non-sterile. Unfolded drapes at first and fold back up at the end of surgery. So not really folding them back up, but just rolling them in a certain way where you're like putting the guck on the inside, right? Only in the lab do we get to refold things. It's super fun. That was sarcasm. Okay. Okay, the way the STs passed each other, good. Yeah. Don't shake the drapes, that's right. No flapping. It's not like you're making a bed, right? Limiting traffic, good. So Gabe, that's a fantastic question. Thank you for asking that. He was saying that they mentioned limiting talking, but what do you do if you sneeze? So when you sneeze, this is going to sound very strange, but you want to sneeze directly at your sterile field. You want to face your sterile field because if you turn your head, that sneeze is going to come out the side, right? So you don't want, it's against everything we've ever been taught, right? Yes. And then if there's any kind of like boogers or anything, you can just let them like just run down. Yeah, that's the worst thing ever. If you have a runny nose, I once saw my preceptor before she put her mask on to go into a case. She is like a diehard scrub tech. Take some 4x4 like dressing sponges, roll them up and tape them underneath her nose like a mustache dressing, and then put her mask on. Or you can stuff them up your nose too, I guess. But yes, we're gonna sneeze at the field. That's a great question. Tammy said drapes are made of special material. Yes, so there's either woven or non-woven, and non-woven are gonna be the paper disposable ones. And there's pros and cons to both of both material, like woven ones and non-woven ones. Ian says the nuance of dealing with drapes as in not even putting it to yourself. Yep. So once you roll up your drapes, you just want to kind of keep them out in front of you, roll everything to the inside, and then throw those in the trash. Same with your gown. You're going to learn how to take that off the same way. Tammy says she's going to have an issue with the sneezing thing. Yes, but you know, if you try to stop a sneeze, you could like pop your eyeballs out of your head. So can we stick nose tampons up there? Yeah, nose tampons would work perfectly. Ian, what's your question? Yeah, I'm with you. No. The answer is no. If just the glove is contaminated, then the circulator can remove that glove. I always say, put your hand out like you're gonna get some money. So if your glove gets touched, then you're just gonna put your hand out like this. The circulating nurse is going to just touch that glove like right here at either side of the hand and just pull that glove off. And then you're gonna be like this, right? Your cuff is still gonna be here. And then that's where we would switch to that open gloving, right? Because with the gown, we saw closed gloving. Open gloving is a different animal, but the nurse would open up another pair of gloves. You could take it with the hand that wasn't contaminated, scoop inside the cuff, and then there's a way that we can re-glove. Does that make sense? Yeah, so here's the thing. What typically happens out in the field is the nurse is going to pull the cuff back over your fingertips when they pull the gown off. That cuff is contaminated. You cannot re-close glove. That is poor technique. So what you need to do is take your sterile hand, get your gown, pull it back so that that cuff is there, and then do an open glove. That is the best technique for doing that. Let me see what else is coming in here. Yes, it's going to be loads of fun. It will be fun, Jonathan, it will. What if the glove snaps when coming off? So when they take it off, they're gonna kind of try to pull it inside out, if that makes sense. So hopefully that junk is gonna be on the inside. Does that help? Can you put a glove over a glove? So this is a fantastic question. Yes, but the time that you would want to do that is when you first scrub in, and that's called double gloving. So if you have double gloved, which is I think recommended by most facilities out there, we only do it for one case in the lab because that consumes a lot of gloves. But there's no trick to it. After you put the first pair on, it does not matter how you get the second pair on, you just got to put them on. And if that outer glove becomes contaminated, it's very easy for the nurse to just pull that off. The one underneath it is going to be sterile. You'll get another pair of gloves and just put another one over it. But you would want to do that at the beginning of your case, not once a contamination occurred and just cover it up. Does that make sense? That's a great question. Thank you for that. Other questions or observations from my M through L, M through Z, I mean. I don't know what I'm talking about. Z comes at the end, I think. Okay, what about my other half of the class? Any other observations to speak of? I wrote down some notes here too. Let me see if we kind of hit on all things. Drape movement to a minimum. Yep. Yep, because there's going to be little blue particles that are going to come off from that drape. We don't want them in the wound if we can help it. Yep, isn't that crazy? It's the same with the screw cap, because that screw cap you have to pull up off from the bottle. So again, you know, once you do remove that, once you pop and you start pouring, you don't want to stop. If you stop in the middle, you're done. Like that, the rest of it is trash. Yes, Sarah, yes, absolutely. And never recap. Never recap and reuse. And I don't know if I told you the story about my one dear nurse that I loved more than anything. Jerry was her name. But she had a habit of only pouring half of the saline into your bucket. And then she would put, because we had like 1,000 ml bottles, and she would put the bottle way up on the shelf, and then she'd want to use it for your next case. And so when she would leave the room, I would always pour it out. And so I went to the purchasing manager and I was like, hey, hardly ever do we use 1,000 mLs. Can we get the bottles that are 500 mLs? And he's like, yeah, sure. That would be cheaper for us. So everybody agreed and we got those. I'll be darned if she didn't do the same thing with the 500 ml that she did with the 1,000 ml. Pour half, set it up on the shelf. I'm like, oh geez. Yeah, not a good practice. It's like backwash, Tori, you're absolutely right. Anything else? Those are good observations. What about the doors? What has to happen to the doors before you start opening stuff? Anything?
They must be and remain closed.
Yes, they should be closed. Very good. Otherwise, our laminar airflow isn't going to work properly, right? I think you guys hit on all the things I kind of jotted down, so great job. Okay, that's it. That's our fast and furious lab review. Any other questions? All right, do you guys want to take a couple-minute break while I get Kahoot up and going? And then you can come back and log into that, and we'll finish up with our Kahoot game, okay? Okay, good job, everyone.